Good afternoon. I hope I don't know how many of you are awake, but indeed I'm very nostalgic to be here after 20 years, and Pune gave me the platform to take off and to come to this stage. And at the outset, I would like to thank the organizing team and the AORA to extend a warm welcome for me here, and it is indeed a pleasure being here to talk to you about the thoracic paravertebral block. New concepts, we don't know what the new concepts we are going to talk about, but I'll just tell you something what happened last night during our banquet. We're just having a couple of drinks with my SRs and CRs. Then I was asking how the meeting is going, how the conference is going. Oh, it's a National Regional Anesthesia Conference, Academy of Regional Anesthesia. I said, doesn't look like, it looks like regional conference. Why is that? A lot of Maharashtrians. Then another guy caught up and said, this after a couple of drinks. Another guy said, oh, we've already been pre-medicated. I think this looks like regional anesthesia. No, it's more of a Puneites. Oh, it looks like local anesthetics. Oh, no. My SR came and he said, if you have a couple more drinks, it'll be GA now. Stop here. Let's go for food. So it was 11:30. So with that note, let's start. What are the new concepts of thoracic paravertebral block? This one? Okay. So nothing new about the thoracic paravertebral block. The thoracic paravertebral block has been here for many years. But what has happened is it is resurgence. The new resurgence of the thoracic paravertebral block has been done with the help of the new technological development and the access to the thoracic paravertebral anatomy, the study and using the ultrasound to do it safely and sound. So there are various indications for the thoracic paravertebral block. As you can see, it can be used for surgical indications for post-op analgesia, as well as for chronic pain issues and other physiological parameter problems like hyperhidrosis and inflammatory conditions like post-herpetic neuralgia. And this can be carried out by a single shot technique or continuous technique. And it can be administered as a unilateral block or a bilateral block. As you can see here, there are various levels of block. As you go down the level, you can apply for the breast surgery, thoracotomy surgery and video-assisted thoracoscopic surgeries, nephrectomies, and they even advanced that to do major abdominal surgeries and pelvic surgery, but the block need to extend further down. To achieve this level of block, we need to know the anatomy first. As Charles mentioned, we have to know the basic anatomy, the gross anatomy, and the zone anatomy before we venture into this process. So the paravertebral space is a wedge-shaped potential space. It is bounded medially by the thoracic vertebral body, the intervertebral foramen medially, and anterolaterally by the parietal pleura, and posteriorly by the superior costotransverse ligament. The contents are, as you can see, the sympathetic ganglion there, the rami communicantis intercostal nerve, and this is bounded by the three intercostal muscles. As we go further, this dissection shows the innermost intercostal muscle disappears there, becomes the innermost intercostal membrane, which becomes the superior costotransverse ligament, which is absent there. That is what's going to give us the space to approach the paravertebral space. This is a cadaveric dissection with the superior costotransverse ligament being reflected back, showing the potential thoracic paravertebral space. The thoracic paravertebral space can be approached by two different techniques, routinely or classically by loss of resistance, by feeling the landmarks. So you can feel the transverse process, hit the transverse process, and you walk down and you enter the paravertebral space by piercing the superior costotransverse ligament. So that is why we need to know the gross anatomy, and we need to concentrate on that before we endeavor into this block. With the new advent of the ultrasound, we can use ultrasound guided technique where you can see the various muscle layers and you can see the potential space. I can advance the needle in plane and then you can reach there safely. And the next picture shows once you inject the local anesthetic in the potential space, you can see the pleura being pushed down with the paravertebral space being expanded. And this study, the anatomical study, what is done is they have dissected the cadavers of multiple patients, and they've seen that the location of the superior costal transverse ligament, it is not oriented straight, it is much more oblique and much more lateral. So what they found is by using the ultrasound probe much more in an oblique position rather than the dead paravertebral sagittal or transverse position, it gives you much more better access and visualization of the space. So with that study, these guys have used the oblique technique, and then they approach the needle from medial to lateral to avoid any injection into the potential epidural space or into the spinal canal. And that is where the needle is being directed to the transverse process and they are walking away. So this can be approached by different ways. You can approach by thoracic transverse. And when you do the transverse approach, what you need to know when you scan is very important to see the anatomy correlation there. You can see the transverse process and the costal transverse joint, and that is much more superficial and also much more lateral. When you scan from medial to lateral or from lateral to medial, if you come down, you see the spinous process there, the transverse process, and you can see the step. So you need to see the step there before you go and see the rib, and then you can angulate a bit more obliquely and then see the superior costal transverse ligament. So again here, just not the gross anatomy, you need to know the osteology as well, which helps us to correlate that with the sound anatomy before we venture to do this procedure. And this approach is paramedian sagittal approach. Again, you can approach by in-plane technique or you can go out-of-plane technique. So you can have different approaches. You have medial approach, you have lateral approach, you have much more lateral approach from the intercostal space directing the catheter towards the paravertebral space. They all have some advantages and disadvantages, but if you ask me which is the best technique to do, I would say if you're routinely using it, you should follow whichever technique is comfortable and safe, and you are confident in doing it, you should carry on with that. And nowadays the surgeons are so helpful and very considerate for their patients as well, and they join our team for pain management. So this is one of the dissections showing that with the reflection of the costal transverse ligament and the innermost intercostal muscle, and see the catheter being threaded into the space. So in this study what they did was they injected the contrast in the paravertebral space and saw the spread of the local anesthetic. In this one they're given the contrast and they've seen the spread, which is averages about 3 to 4 segments. And you see the cloud-like spread, that's what you expect to see there. And this study from Australia, from the Melbourne group, they injected aniline dye to see the spread unilaterally and bilaterally by injecting at 2 different sites. One site they injected at one point, and the other site they injected at 2 sites, and they found that average spread is about 4 to 6 segments and the maximum goes about 10 segments. And you can see the nerves involved there, the sympathetic trunk, rami, the spinal nerve, and the intercostal spread. The intercostal spread and the epidural spread is what is going to extend your block. If you're going to do a single shot injection, you can expect the block to go more down rather up because of the gravitational situation. Well, once you identify the space, you're happy, you injected the local anesthetic or you fed the catheter in, the catheter doesn't stay where you expect to go. they found that the catheter can migrate or can go into various spaces. It can go prevertebral, paravertebral or paravertebral space, paraspinal, epidural or subcutaneous. So for the variability of the spread, they have done the dissections and seen that it is not constant. You have to be very careful before you inject and to expect the block to work and the pain relief to be obtained. I'm just going to show a thoracic paravertebral block. Okay, this is a video approach with the paravertebral transverse approach with the in-plane technique. That's medial, that's lateral, that is posterior, that is a medial. So the needle is going to come from there, and that is the external intercostal muscle, that is the internal intercostal muscle, that's the paravertebral space. So that is the innermost intercostal muscle. So he's piercing the external intercostal muscle now. The internal intercostal is there, and the innermost intercostal is pierced, and then he pierces the superior costal transverse ligament there, and then it enters into the paravertebral space. And once you inject the local anesthetic, you can see the lung with the pleura there. You can see that being dipped down. So when you do this in a awake patient, you need to warn the patient that they will feel some discomfort when the pleura has been pushed, because they will feel the parietal pleura pain, which has been yeah, can you see that? Yeah. So that is what you expect to see with the ultrasound. These things we will not be able to see when we're going to do it with the landmark technique or loss of resistance technique. So this gives us the safety, and also later you can scan further up and down to see the extent of the spread. But it can be used for post-op analgesia or perioperative analgesia. Well, after doing all those things, so what is the evidence that taking all the risk of doing paravertebral block when there are other techniques of doing it? Okay, this study comparing the paravertebral block to the gold standard thoracic epidural, they did a meta-analysis, and the 10 trials with the help of 520 patients, they found there is no difference in pain score between the thoracic paravertebral block and the epidural block. Rather, the paravertebral block had less number of complications in terms of cardiorespiratory function and less of nausea and vomiting and urinary retention. And the amount of failed paravertebral block was much less than the thoracic epidurals in this study, and they said the paravertebral block is equally efficacious for post-op pain relief compared to thoracic epidural. And this systematic review, which is published, I think there are a couple of overlaps, and this has been already highlighted earlier in Dr. Arya's talk, and they evaluated the thoracic epidural to other modalities of regional blocks like paravertebral, intrathecal, intercostal, interpleural and systemic opioids, and they found the complications are less with thoracic paravertebral block compared to the epidural, and thoracic paravertebral block is equally efficacious, whereas the intrathecal opioid or intercostal blockade is not just enough. We need to supplement that with systemic opioids. And this study again shows the comparative efficacy of the paravertebral block analgesia involving 50 previous one. Yeah, the randomized control trials involving 8 studies with 6 breast surgeries and 2 herniorrhaphy, and they found less of cardiorespiratory problems, less of nausea, vomiting, and less complications. And they did a national survey in UK, and they found that there's increasing trend to use paravertebral blocks for post-op analgesia, but for surgery they still use the gold standard epidural analgesia. So, to summarize, the paravertebral block is not a standard simple block, it is an advanced block. We all don't do it, so you need to be cautious before doing it because of the risks involved. But it has benefits. It can be done unilateral or you can do bilateral. Less motor blocks, less cardiovascular problems, less urinary retention, and the new thing which is coming up with the thoracic paravertebral block is reduce cancer recurrence, and a lot of new studies are coming, and I think a study from Hong Kong is going to be published sooner, using the thoracic paravertebral blocks and the reduction of cancer recurrence in breast surgery patients. This study has been carried out for over 5 years. Thank you.